Let's do this. We're doing these three. So this actually might take kind of a long time. Okay, so we're going fast. A patient with emphysema becomes acutely dyspneic, slow breathing, or shortness of breath, while ambulating. Which action should the nurse take first? Apply a non-rebreather mask at 50 liters a minute, coach pursed breathing, and place client in tripod position, encourage rapid shallow breathing, have a client lie supine with legs elevated. Okay, this person can't breathe. So supine with legs elevated. If somebody can't breathe in acute care, what is the first thing everyone does? Sit them up. That's like the first thing. So not that one. Non-rebreather. I don't know what the hell that is. You don't probably know what that is, so we're just going to cross that one off. Rapid shallow breathing. Okay, you can't breathe. Does that help? Does that help? No. Okay. Clearly, coach purse breathing and tripod position. Tripod position. I mean, that's like the universal sign for something's wrong with my airway and I can't really breathe, and this is the position I can breathe in. Okay. While palpating the precordium, the nurse feels a sustained, forceful lift at the left sternal border. Okay. Left sternum is all that's saying on the side of the left side of the sternum. Which condition is most likely? Aortic stenosis, blood not moving in the aorta. Mitral regurgitation, blood going back through the mitral valve. Pericardial effusion. I think it has something to do with the pleura or something. No, that's not. No, it doesn't. That's the outside of the heart. Or right ventricular hypertrophy. Well, let's see. She feels a forceful lift. Something is bigger than it should be on the left side. Wait, I think that's right. Yeah, I don't know why I'm second guessing myself. It's this one. Just 99% of the time, it's going to be hypertrophy. Something's wrong. You know. Which instruction is essential when teaching a patient about 24-hour urine collection for creatinine clearance? Okay, 24-hour urine collection. You're collecting every sample of urine for the next 24 hours. What do you want to do? Save the first void, discard the first void, and then collect everything else. Keep nighttime urine only. Use any missed voids as an endpoint of the test. Okay, well, we can take that one out because that's not 24 hours. We can take this one out because that's not 24 hours. So then we're between these two. Do we save the first one, or do we get rid of the first one? I can't give you any rationale as to why. Maybe I can. Don't look at the answers. Don't look at the answers. This isn't even the right one. It's this one. Okay, that's just, it establishes the start time. I don't know. Just remember, 24 hours starts after your first pee. Oh, that totally makes sense. That totally actually makes sense. 24-hour collection starts after your first pee. So you're going to get rid of that first pee, and from that point on, you're doing it all. The nurse suspects pleural effusion in a client with dyspnea. Which assessment findings support this? Select all that apply. Okay, select all apply. We know how to do this. We're taking every single one and we're making it a true or false question. Dullness to percussion over the affected area. Are you going to feel dullness or hear or whatever? When you percuss it, is it going to be dull? True or false? True. Hyperresonance to the percussed area. Okay, well, if we said true to the first one, can the second one be true? Can you hear dullness and feel? I don't really actually know. Or hyperresonance? No, that's false. Decreased or absent breath of sound over the effusion. And pleural effusion. This is the pleura in the lungs. So, and I'm pretty sure that means fluid. So basically, fluid around the lungs. I think. Don't. Okay. Sorry. Decreased or absent breath sounds over the effusion. Okay, true or false? We have a plural effusion. Are we going to hear breath sounds easily? I don't think so, so that one's true. We have 2 truths so far. Plural rub that persists with breath holding. Okay, what do you think? I don't think so. I don't really know why that has anything to do with it. And then asymmetric chest expansion. Yes, that's true. So we have A is true, C is true, and E is true. So A, C, and E are your answers there. I already talked to her today. She's not gonna have any questions on there about S1 or S2. But if you would like to know, it's a systolic murmur. Just think about where you are in your locations of that. An older adult presents with acute confusion and foul-smelling urine. Okay, what do we've already got something there. Older adult, confused. What's your first thought? What is the first thing you think of? Okay, UTI, yes. Then you see foul-smelling urine. Yeah, okay, confirmation. This old bitch got a UTI. What is the nurse priority action? Encouraged to increase caffeine intake, obtain a UA, administer prophylactic antibiotics immediately, restrict all fluids until lab result return. Okay, well, we are already knowing UTI. I mean, obviously, we all know the answer here, but I'll just do some explaining. Increase caffeine intake. I mean, I don't know why this is explicitly bad, because I feel like caffeine makes you pee more, but obviously that's not going to be your answer. Restrict all fluids. You want to piss that shit out. So no. Administer prophylactic antibiotics. You might think you know, but you need to know. You need to figure out, is this a bacterial infection? So clearly, before you give antibiotics, you should probably say, we're going to get you tested first. You know, that should probably be the first thing that you do. Which technique reflects the correct posterior lung auscultation? Listen over clothing with a bell. Come on, we're not dumb. Compare side to side, C7 to T10. Bare skin. Only listen at the base while the patient whimpers. What? Whispers. Ask the patient to take rapid breaths through their nose. Okay. I mean, come on. This is easy. Obviously the one with the most detail. Okay, true, or I'll select all apply. We're going true or false again. Which findings are most consistent with left-sided heart failure? Okay, I'm going to give you a hint. L, left lung, left lungs, left pulmonary edema, left lungs, left edema in the lungs, right-sided heart failure, right hand, right arm, right leg, right foot. Peripheral edema. Right-sided heart failure, you're having your appendages are filled with fluid. Left-sided heart failure, pulmonary edema, your lungs are filled with fluid. Okay, so now we got that. Okay, left-sided heart failure, orthopnea and paroxysmal nocturnal dyspnea. Oh God. Okay, we'll break it down. Orthopnea. What is orthopnea? Ortho, that means body, bones, maybe laying down, orthostatic hypotension, and nocturnal dyspnea, that means shortness of breath, probably at night, nocturnal, okay? Night, shortness of breath, you're laying down. Orthopnea, I'm laying down, I can't breathe. I can't breathe while laying down. Yes, that is true. So orthopnea is you have basically you can't breathe when you're laying down because you have fluid in your lungs. So that fluid is evening out instead of, I don't know how true this is, but, you have a cup of water. If you set it down on a table, all the water's in the bottom. If you lay it on the side to where it's not like, dripping out, that water kind of moves around and it follows the edge of the glass. So just think about that. If you have fluid all over your lung at this point, it's going to be hard to breathe. Crackles at lung bases. Well, where's the fluid? Same thing. Water, cup of water's on the table. Where's the water? At the bottom. So true. We have two truths. JVD. Okay? I like some of the Gaga song. What the fuck does she know about cameras? What the fuck does JVD have to do with... Sorry, that was really weird. JVD has nothing to do with that shit. Then peripheral pitting edema. Say it with me now. Left-sided heart failure. Left lung. Right arm. Right leg, right foot, right hand. No peripheral edema. Dyspnea. I don't know why I can't say that word anymore. On exertion. Shortness of breath on exertion. Okay, I'm trying to run a mile. I have fluid in my lungs. Yeah, I'm out of breath. So true, and true. A, B, E. Okay. The nurse notes cool, pale, hairless legs with diminished pedal pulses. Which patient report best aligns with this assessment? Okay, well, let's just take this. Cold, pale, hairless, no pedal pulses. So at that point, you should say, okay, this is either going to be venous insufficiency or arterial insufficiency. What's what? The best way that I can think about it and associate it with is when you look at arteries on like a diagram, they're always red. Always red. Veins are blue. So if you didn't have the red blood going through you, and I mean, this is not scientifically, how that shit works, but you would be pale. You don't have the red going through you. You don't have your red undertones anymore. You're suddenly a little blue because all you got is your blue veins. So then you should know cool, pale, that's artery. Hairless legs is just another confirmation for it. For some reason, you stopped growing hair. So now we know that is insufficient arterial or artery insufficiency. So then you say my legs ache less when I elevate them. The pain improves when I stop walking. My ankles are most swollen at night. My skin turned brown around the ankles. Okay, that's an identifier for another one. So this one is my pain improves when I stop walking. I don't know why, but it hurts your legs and it hurts on exertion. You're walking upstairs. Well, not even upstairs. You're walking and it hurts. It doesn't feel good. So when you stop walking, the pain stops. Associate that being cold, being pale, having no hair, and it hurting when you walk with arterial insufficiency. Which finding requires urgent intervention? Dysuria and frequency. Dysuria, what is that? I'll give you a second. Okay, yeah, you're right. That's painful or diminished peeing. Not diminished, but like it hurts to pee. Inability to void with suprapubic pain and bladder distension. Nocturia times 2. What's nocturia? Yes, nighttime peeing. Cloudy urine without fever. Okay. This one could be our winner, but what's the identifier? Without fever, no infection. Well, maybe. Nocturia, night peeing, whatever. Painful peeing and frequency, okay. That could just be a lower UTI, but this is urgent. This person can't pee. This hurts. You gotta stick that straight cath in them right now. During inspection, the nurse observes an intercostal retractions and the use of the sternocleidomastoid muscle. What is the best immediate action? Okay, sternocleidomastoid muscle, that's an accessory muscle for retractions. So this person's having a hard time breathing. So encourage them to cough and deep breathe, increase activity to mobilize the secretions, escalate oxygen support per protocol and notify the provider, document and reassess in 60 minutes. Okay, well, this person's not having a good time. So document and reassess in 60 minutes. Take that one out of there. Encourage cough and deep breathing. I mean, it doesn't really... Cough would be oh, I heard crackles in somebody who's 25 years old and is an athlete and has never smoked a cigarette in a day in their life, who is so healthy. Hey, I'm hearing crackles. Could you cough for me really quick? Okay, let me listen again. The crackles are gone. That's what the coughing is. Increase activity to mobilize secretions. I mean, a person can't breathe, you're going to go tell them to run a mile. So obviously escalate oxygen support and notify the provider. Same thing about, oh no, we do have, oh, S1, S2. Wait, no, we are learning S1, S2. Sorry, I don't know why in the fuck I said that was, I don't know why I said S1 and S2 we do need to know. S3 and S4 we don't. Um, Harsh blowing sound is heard between S1 and S2. The right upper sternal. How should this be documented? This is systolic murmur. Right upper. Right upper sternal border. Where are you in the right? You're at the aortic. That's S2. Systolic. Don't ask me anything else. I don't really know. Okay, what's true about S1 and S2? S1 is louder at the base. S2 is louder at the apex. S1 is the mark of a diastole. S2 is the mark of systole. S1 is louder at the apex. S2 is louder at the base. S1 occurs with semi-lunar valve closure, and S2 is with the AV closure. Okay, let's think about it. We have two things that say the exact opposite. So we can probably conclude from our NCLEX taking skills. One of these is the answer. Where is S1? I'm going to give you a hint. One is at the second intercostal space, one is at the fifth intercostal space. One goes with A, one goes with M. They actually both go to A, but you know what I mean. So, here it is. 2, 2, 5, 1. Second intercostal space, S2. 2, 2, 5, 1. Fifth intercostal space, S1. 5, 1. Okay? It's flipped. S1 is at the bottom, S2 is at the top. The apex is at the bottom, the base is at the top. So 2, 2 at the top, 2, 2, S1 at the bottom, apex. So yes, it's C. S1 is louder at the apex, S2 is louder at the base. Which factors increase a female patient's risk for UTI? Okay, select all that apply. True or false? Rapid round. Short urethra. Do we have short urethras? Yes. True. Postmenopause. True. Frequent catheterizations. I'm getting catheters all the time. True. High fluid intake. I'm pissing all the time. False. No. Bladder outlet obstruction. I have an obstructed bladder. Oh my gosh, pee's just sitting in my bladder. It's just growing bacteria. True. All but D. Oh my god, this is gonna take forever. We have so many of these. The nurse hears a high-pitched musical sound predominantly on expiration in a client with chest tightness. Which intervention is most appropriate? Okay, well, let's think about this. High-pitched expiration. What is that? We got high pitch, so then we can go and say, okay, well, it's going to be one of ours. Is it going to be sibilant? Is it going to be fine? Fine crackles, sibilant. Expiration. What's expiration? Crackles or wheeze? Expiration, wheeze. Breathing out. Is that right? That's not right. That sounds like Strider. But you know what I'm saying. So at this point, you say, okay, this is sibilant wheezing. Wheezing. What is wheezing? Bronchodilation. I mean bronchoconstriction. What do you need to do? You need to get that airway open back up. So what are you going to do? Encourage them to cough to clear the crackles? Well, we just determined that this is not crackles. Administer bronchodilators. Apply chest percussion to mobilize secretions. Well, we've already determined that these are wheezes. Initiate a chest tube to relieve air trapping. Is this a pneumothorax? What are we doing here? No. So clearly, give him the goddamn albuterol. Before palpating the carotid arteries, the nurse should first palpate both simultaneously, auscultate the bell for bruits, ask the patient to cough, measure the BP. Okay, this is carotid arteries. What the fuck do we need to know the BP for? No, we don't. Why would they need to cough? I don't know. They don't. Palpate both simultaneously? Yeah, let's just fucking kill them. No, clearly you're gonna listen. You're gonna listen before you feel. You know, we did it in lab today. Well, I did it in lab today. But listen before you feel. Okay, which teaching should be included for a patient prescribed prananoxaparin pyridium? Pyridium. This medication treats the infection. Urine may turn orange. Take it bedtime only. Stop the drug if your urine changes colors. Okay, well, so I don't know if y'all motherfuckers have had an UTI before, but I used to get them literally every single time I had sex until I was like grew a brain one day and was like, I need to be peeing after. Like this is happening too much. I was also um it, I was younger than I am right now. So I would chronically take Azo, and the thing about Azo is it turns your pee neon orange. This is Azo. This is over the counter. This is you go buy it from Walgreens. I think it's kind of expensive now, but this turns your pee orange. Pyridium turns your pee orange. Uh, which findings are typical of the right lower lobe pneumonia? I don't even know if we need to know this, but I'm just going to tell you. True or false? This is select all that apply. Fever and tachypnea. Okay. Pneumonia. What's pneumonia? A viral. That's right. Infection. Fever. Fast breathing. Yes. True. Hyperresonance to percussion. This is over the lung. We don't hear that here. So no. Crackles or bronchial breath sounds over the right lower quadrant. No, you know what I'm saying. Lobe. Clearly, yes, true. So we have AC, decreased breath sounds over the uh, fucking lobe. True. And then E, no, sorry, dullness to percussion. So we're not hearing hyperresonance, but we are probably hearing dullness. So yes. And then we have the AP. She's assessing the AP. The nurse notes a displaced diffused PMI. What does PMI mean? Point of maximal impulse. This likely indicates, okay, well, let's think about this. We're on the AP. Where's the AP? Yep, left side. So we can probably say it's not right. We can probably say that it's not AFib because I don't know if you guys know what AFib is, but it's when the top of the heart kind of quivers and the bottom is functioning normally. So the top is just kind of shooting blood out pretty fast, and the bottom is going, at that normal bump, 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 bump. Yeah, they have to shock AFib to fix it. VFib is the opposite, it's the inverse. It is that bottom portion is quivering while the top remains normal. That's what you call a heart attack. I'm pretty sure. Because MI is different. Or no, sorry, cardiac arrest. Cardiac arrest. MI is a heart attack. Cardiac arrest is a VFib. So, sorry, we don't need to know this. It doesn't matter. Yeah, so your answer here is going to be left ventricle hypertrophy. It's just think about where you are location-wise, and then you've got a fucked up heart sounds. Something has happened that has caused your, your heart to get bigger and not be the way that it was supposed to be. Okay. Now we have bilateral lower extremity pitting edema at 6 millimeters that remains for several seconds and legs appear swollen. How should this be graded? +1, +2, +3, +4. Okay, well, so we're looking several seconds and, a normal 6 millimeters. That's not crazy, but it's not good. So we know we're not 1 and we know we're not 4. 4 you're going to be at minutes. 2 or 3. So then you're between these two. I'm going to be so honest with you guys. I only know the answer to this question. I cannot give rationale as to what the other one is, why it's not 2, but it's 3. And the indicator is 6 millimeters in several seconds. I think 2 is going to be less. I think several seconds is the indicator here. Because 2 is like, it's kind of, like, the legs don't appear swollen, but you got a little something going on. Okay, and then bedside tool to evaluate urinary retention after voiding. I mean, bedside tool, come on. We're not ultrasounding the peripheral arteries. We're not doing a CT that's not bedside. And why would we do a kidney urinary bladder or urethra bladder x-ray? I guess we could, but is that bedside? Obviously, it's a bladder scanner. Okay, let's go fast. And then I guess I'm gonna cut this in half. Like maybe I'll just do 2, 2, 2, 2, and then maybe just 1. Um, During cardiac auscultation, listening to the heart, the nurse identifies an extra heart sound immediately after 2. Oh, once again, see, we don't need to know this, but it's S4. Okay, here's a little trick when it comes to Bruit, whatever the fuck it is, and thrill. Thrill is touch. T, touch. T, temperature. You can feel temperature. You touch temperature. You touch the stove. You go, ow, that's hot. I touched it. T, thrill. Thrill and T. You feel vibration. Bruit, first of all, it can only be heard on the carotid, I'm pretty sure, but it's like a whooshing sound. Bruit, think about when you have like a bee like by your ear, you hear it. You hear it with your ears. And it, you crumple up your shoulders really high and you push your neck down. You're like, "Oh, bee flew by my ear. A bee buzzed in my ear. I heard the bee." Okay, there we go. Here's my little lesson for the day. When assessing the client's apical pulse, I don't know why it says impulse, the nurse palpates a vibration that feels like a cat purring. What does this indicate? Palpates a vibration. She feels a vibration. What is that? She felt it with her hand. She touched it. T, thrill. Which assessment finding indicates a normal S1 sound? Okay, where's S1? Well, let's think about it. 2, 2, 5, 1, 5, 1. Where's 5? APE, TM, mitral. That's apical. That's on the 5th. Okay. Okay, closure of the mitral and tricuspid valve. M, T, E, P, A. That's backwards. Sorry, I don't know. I learn differently than you motherfuckers. I can't remember the All People Read Times magazine or whatever the hell it is. So yeah, closing of the mitral and tricuspid. The nurse hears a blowing, swishing sound over the carotid artery. What is this? Okay, she hears a blowing and a swishing sound. Hears it. I heard it. It buzzed in my ear like a bee. Bruit. B. Brewy. Bruit. She says it weird. Okay, a client with JVD at 45. A client prevents with JVD at 45 degrees. Which condition is most likely associated with this? Okay, here we go. How do I explain this? Left lung, right arms. Arterial insufficiency. This is a vein. Jugular vein. So we can already say no. Hypovolemia. You don't have any liquid in you. So why would you would be like almost overfilled in your neck. So clearly we are in between these two. Left is lung. Associated with lung. You cough shit up. You have crackles. You have dyspnea. You're out of breath. You can't breathe. This is more different symptoms. This is more fucking with your, like, arterial shit, like peripheral, whatever. Just know, right-sided heart failure, JVD. Associate those two things. I can't connect it for you. I don't know how to do it. When auscultating at the second left intercostal space near the sternum, the nurse is listening to which cardiac area? Okay. Second left. 2, 2, 3, 4, 5. That's your pattern. Now you gotta just figure out what way is left and right. Okay. Well, you start on the right side. That's your aortic. Then where do you go? Your pulmonic. Which finding would the nurse expect for a client with chronic venous insufficiency? Okay, this is where they don't have blood going through their veins. Their venous. Their veins are kind of static. Okay, pale, cool skin. What color is a vein? Blue. No. We'd be blue if we didn't have arteries. Brown discoloration around the ankles? Maybe. Let's think about that. Keep that one in your head. Thin, shiny skin. I don't know if I've talked about this. That is a symptom of arterial. And then absent pedal pulses, obviously, we had that in the other example. So, brown discoloration around the ankles. Why? Okay, this might not get you anywhere, but it might help you. Venous insufficiency, your blood is going really, really slow, and it's leaving some type of deposit. So also think about like gravity. Your ankles are like the last to get blood, and they have to work the hardest to get back up to the heart because you're fighting against gravity. So it's in your ankles for longer, and it leaves these deposits behind, and it just turns your ankles brown. I don't know why, other than everything I just explained. Okay, how do you assess JVD? Upright 90, supine, head elevated 30 to 45 degrees. Lay on their left side. Yep, 45 to 30 degrees. We've only done that like a million times. We don't need to know S4. I actually don't even think I did this one. It's fine. Where should you palpate if you're trying to find if the foot is getting circulation? The popliteal, which is the knee. Post-tibula, which is the ankle. Oh, shit. Radial or brachial. Radial is your wrist. Brachial is your armpit. Yep, you got it. Posterior tibial. The nurse palpates a +3 pitting edema on both ankles. How should you document this? Slight pitting, no visible swelling. Deep pit that remains for several seconds. Legs visibly swelling. Deep pit, grossly distorted limbs. Trace edema only. Yes, it is B. Deep pit that remains for several seconds. How should you confirm an MI, which is a what? That's right, heart attack. I don't know if you guys know this. I just knew this. I don't know the reasons, but it's just a specific, like some type of like specific thing comes out in you, and it's your troponin. I don't know why, but that is elevated when you have an MI. Nurse palpates a heave along the sternal border. Which condition is likely responsible? Okay, we're back to the left sternal border. Okay, absorb the information. So, I don't know if you remember this. It's opposite. That's right ventricular hypertrophy. I don't know why, but it's flipped. Okay. What supports the diagnosis of left-sided heart failure? Say it with me. Left lung, left-sided heart failure. JVD? No. Peripheral edema? No. Crackles and dyspnea on exertion? Maybe. Or ascites, clearly. You're gonna have lung issues. Okay. Also, I cannot give you any other information other than what this question has. Loud murmur with a palpable thrill. You can feel the thrill. It's grade 4. I don't know why. Just, you can do your own research. Palpating pulses. The nurse notes an irregular rhythm. What should the nurse do? Document as normal. No. Oscillate for a full minute. Maybe. Notify the provider. I mean, maybe you should just figure out the rhythm first. Or check the cap refill. Yep, clearly we have done this 1,000 times and said it 1,000 times practicing for our lab. You should do it for a full minute. Which age-related change is expected in older adults during a cardiac assessment? Increased elasticity of arteries, decreased orthostatic hypotension, increased systolic blood pressure, louder S3 and S4. Okay, when you're old, do you think you get more elastic or less elastic? Do you get wrinkly or less wrinkly? That's right, you get less elastic. Decreased orthostatic hypotension. I mean, not every old person has it, but they definitely are more at a risk for it than young people. Increased systolic blood pressure. I'm just gonna give you a little spoiler. Yes, it's this one. When you get old, everything kind of stiffens, you know? You just kind of become like this, like, achy little hard piece of, like, wood. And you're just so stiff. It's the same thing with your arteries. Your arteries lose elasticity, so it's going to increase your blood pressure. A nurse notes cool, pale legs with a diminished dorsal Whoa, we've done this before. Okay, we've done this before. What is this? Cool, pale legs, diminished pedal pulses. Yes, that's right, arterial insufficiency. Nursing assessment is essential before populating the carotid arteries. Oh, which one is? Auscultate the carotids for bruits. Measure the BP bilaterally. Also, if you hear these, you need to stop the assessment. I don't know why, but I just remember she said that in class. Measure the BP, ask the patient to cough, palpate both arteries simultaneously. We've done this question before. I'm going to let you answer it. Yes, that's right. We need to auscultate before we palpate. Okay, last question. Which of the following findings would the nurse expect in a client with chronic hypertension? Chronic hypertension. Okay. Left ventricular hypertrophy. True or false? True. S4 heart sounds. True. We don't think we know that. Bounding carotid pulse. Why would it be bounding? Because your pressure's taken up. True. JVD. False. Bradycardia. False. Okay. Good talk, everyone. I'll see you in the next one. How do I just stop this?